Hey guys, this is the diabetes lecture, and part one of this lecture, let's start by talking about the anatomy of the pancreas. So the pancreas is a long organ, lies in the upper abdomen, extending from the curve of the duodenum and going over to the spleen. If we had to talk about the main functions of the pancreas, that would be twofold. First is the endocrine function, excretion of hormones, and then the exocrine function, which is part of the digestive function in the body. The hormonal function, the main hormones that the pancreas secretes are insulin and glucagon. And these help regulate blood glucose levels in response to carbohydrate metabolism. Insulin itself allows glucose to enter the cells to use for energy. Basically, insulin helps regulate our body fuels and the use of body fuels. Glucagon is secreted when the body recognizes there's a decreased glucose level, and so it's going to stimulate the liver to convert glycogen into glucose, which will then help raise the overall blood glucose level in the body. The cells of the pancreas are what produce these hormones and constitute about 1-2% of the mass of the pancreas. There are different types of islets of Langerhans, so the islet cells are what are secreting the hormones. And so different types of islets are alpha cells, beta cells, and delta cells. They each have a different job and do different things. So alpha cells produce glucagon, which, like we just said, converts glycogen to glucose in times of need where the blood sugar level needs to be raised. Beta cells are producing insulin in the body, and insulin basically, like we said, causes glucose to move into the cells from the bloodstream, lowering blood sugar levels. And then delta cells secrete somatostatin, and it does a couple different things. It inhibits release of glycogen and insulin, as well as secretes gastrin, which increases secretion of stomach acids. Whenever we're talking about the disease of diabetes, mainly we're talking about these beta cells that produce insulin and the effect that it has on those cells. So the role of insulin specifically plays a big factor with looking at glucose, fatty acids in the body, and proteins in the body. With glucose, and this is kind of the most, I would say most common area that we think about with insulin regulating glucose levels, but insulin secretion stimulates active transport of glucose into the cells. So insulin is going to tell those cells to take up that glucose to be used for energy in the body. With fatty acids, when insulin is secreted, it helps promote conversion of fatty acids into fat, which then gets stored in adipose tissue in the body. Also inhibits conversion of fats into glucose, which is important when we talk about states of ketoacidosis and how fats are broken down in the body in times of decreased levels of insulin to be able to promote glucose to go into the cells, and so then the body will start breaking down fatty acids, which is exactly opposite of what we want to happen. And then when there's a lack of insulin or just total absence of insulin, we see fat stores break down. This increases triglyceride levels in the body, which then can become stored in the liver. And as I mentioned, when there's a lack of insulin, the fat stores, fatty acids get broken down into ketones, and then that's where we get ketoacidosis, which is a very serious condition. And then protein in the body, insulin helps enhance protein synthesis in the tissues of the body. It also inhibits the conversion of protein into glucose. Same idea with the fatty acids. When proteins and fatty acids are broken down, we get ketones, acidity building up in the body, leading to a state of ketoacidosis, which is very dangerous. With proteins, when there's a lack of insulin, we also see that there's extra protein then available that can be converted into lipoproteins, and that will ultimately increase our risk of atherosclerosis and coronary artery disease. So that does have a direct correlation to cardiovascular system there. And also when protein storage halts, protein and amino acids are left in the bloodstream, and that can have effects on the body, causing things like weakness, poor organ function, increases the risk of gout. So lots of negative effects there. So insulin plays a major role in regulating these different components in the body. When you look at the liver and glucose levels, the liver stores excess glucose molecules, and those are stored as glycogen, and that process is called glycogenesis. When glucose levels drop in the body, the liver will sense that, and it will release glucose back into the bloodstream. And through that process, how that works is it converts glycogen to glucose, which is called glycogenolysis. And then also breaking down fats and proteins to make glucose. When glucose stores are depleted, gluconeogenesis is what that process is called. But again, that would cause, when fats and proteins are broken down, that can cause a state of ketones building up and acidosis. When we look at dysfunction of the pancreas, by definition, that is characterized by insufficient or absent insulin, or the body's basically inability to use insulin. So with diabetes, there could be different things going on. Not every person with diabetes has the same type of dysfunction going on. There's definitely variations in how diabetes occurs, but the one thing that does remain the same for everyone with diabetes is that it is a very serious chronic disease that has a lot of very serious complications that can go with it. The different types of diabetes, the two main types that we're going to focus on is type 1 and type 2. Type 1 is only about 5 to 10% of the diabetic population. That correlates to about 1.25 million people. Primarily though, the most predominant is type 2 diabetes, 90 to 95%. Type 1 diabetes formerly was known as juvenile onset diabetes. Typically we see this diagnosed more so in younger ages, not all the time, but it could be somebody maybe in their 20s or so that gets diagnosed, but usually we're talking childhood with type 1 diabetes. Type 2 diabetes, this has formerly been known as non-insulin dependent, or also may have heard it called adult onset diabetes. So primarily in the adult years is when we're seeing the onset with type 2. There are other types of diabetes like gestational diabetes that occurs during pregnancy, but for the endocrine lecture we're going to focus on type 1 and type 2. To give you some statistics, in 2015, 30.3 million Americans had diabetes. That's 9.4% of the population. Along with that, of those that were known to have diagnosed with diabetes, there's also 33.9% that had what we call pre-diabetes, on that edge of heading over into a state of diabetes. And then an estimated 1.4 million new cases they estimate will be diagnosed each year. And the cost of this, treating diabetes and just health management, correlates to about $245 billion. And then diabetes is the 7th leading cause of death in the United States. So let's start by focusing on type 1 diabetes and just what is going on pathophys-wise, what's going on in the body. So like I mentioned, this is typically diagnosed in younger years during childhood. Type 1 diabetes is an autoimmune disease. There is an autoimmune triggered destruction of the pancreatic beta cells, those cells that secrete insulin. So when those cells are attacked and start to be destroyed, that means we have a decreased ability in the body to secrete insulin. So insulin levels are reduced and continue to decline until they get to no insulin secretion whatsoever. When that happens, without insulin, glucose cannot move into the cells. Therefore, glucose stays in the bloodstream, and that results in extremely elevated blood glucose levels. And I'm talking significant elevation, where these patients can come in before they're diagnosed. At that initial diagnosis time, they can come in with blood sugars of 500, 600, 700 pretty easily. So it is a significantly elevated blood sugar. We don't know exactly what triggers this autoimmune process with type 1 diabetes. There has been some research that shows there's a genetic component involved, so some kind of a family history, genetic predisposition, potentially viral trigger, some kind of a viral infection in the body triggers an autoimmune response. We don't know exactly what it is, but there are definitely some risk factors there. Some research has shown that about 80% of people with type 1 diabetes have developed autoantibodies against the islet beta cells and insulin. So they specifically attack those things in the body. So research has shown those autoantibodies are present, making this an autoimmune disease. So with type 1 diabetes, there's increased glucose levels, and this causes osmotic diuresis to occur. This state here is what's going to cause a lot of these very characteristic classic symptoms. So with that, there's excess fluid in the bloodstream, and then what we're going to see with that is increased urination, increased urine output, so polyuria. With that significant amount of urine output, dehydration is going to ensue. Eventually, they will get to a state of dehydration, intracellular and intravascular dehydration. So when these patients come in at diagnosis, they are typically profoundly dehydrated. Blood is filled with glucose, extremely elevated glucose. This is going to increase the osmolality. This is going to increase that thirst center, causing them to have polydipsia, that increase in thirst. And then stored fat gets broken down in the body for fuel and energy, because if there's no insulin to promote that movement of glucose into the cells, the body has to find another way to get energy and fuel into the cells. So the body starts to break down fats and proteins, and that's going to cause then a state of increased hunger, so polyphagia. So this classic triad of symptoms that we see, polyuria, polydipsia, polyphagia, very common with a new onset type 1 diabetic. With the breakdown of the fats and the proteins in the body, okay, that's where, because it needs it for the energy and the heat in the body, that's where we're going to see this state of ketoacidosis. When fats and proteins are broken down, ketones are produced, and then we get acidotic. So DKA, diabetic ketoacidosis, is a common diagnosis that we're going to see for a new onset type 1 diabetic. Age of onset, like I said, is typically in childhood. Usually 10 years old up to 15 years old is kind of the average age that is diagnosed, but there are plenty of kids that are diagnosed younger than 10 and plenty that are older than 15. But that's kind of the average age. The onset of symptoms is very abrupt, but that does not mean that the disease just now onset. There has been this long preclinical time where the patient has not been symptomatic yet, but that autoimmune damage has been occurring prior to that point. So that destruction of the beta cells has been happening in the body. They just didn't know it yet. And now they're at the point where they're symptomatic and they come in for treatment and they're diagnosed. But by that point, they say somewhere between 70 to 90% of their pancreatic function is lost by that point. So the etiology behind type 1 diabetes, there's a lot of research that is showing specific genes have been identified that are linked to type 1 diabetes. So if that runs in the family history, there is a genetic predisposition there. Potentially some environmental factors, things like a viral trigger, a viral infection that triggers this autoimmune attack. We do see this also diagnosed more frequently during winter months when we see more of those viruses circulating around, more sickness, more illness during that time of year. And then as I mentioned, the autoimmune disease, if autoimmune diseases tend to run in the family and that genetic predisposition is there, that increases the risk. And then, of course, anyone who's had to have the pancreas removed for any reason would lose that beta cell function then, of course. So the signs and symptoms with type 1 diabetes, we've mentioned a few already, but that very classic triad of symptoms, polyuria, polydipsia, polyphagia, all occur because of the changes that are happening in the body with the increased glucose levels and the effect that has on the urination, the thirst center, and then the hunger. So those are very, characteristic symptoms. Weight loss is seen even though they have increased hunger, increased food intake with the polyphagia. They still can have a weight loss and decrease in that because of the breakdown fats and proteins in the body. Fatigue, just with the effects of the high glucose levels in the body and the breakdowns of the proteins, fats, all of that can have an effect of fatigue. Their fasting blood sugar is going to be significantly elevated. They're going to be at a higher risk for infections because when we have high sugar levels, bacteria tend to want to grow there. A tendency to develop ketosis or that ketoacidosis, as I mentioned, which is breakdown of fat stores along with protein in the body. Slow wound healing and vision changes, those directly correlate to the vascular issues that occur with diabetes. So with the slowed wound healing, that's due to the effects of peripheral vascular disease, or PVD, and then vision changes directly correlated to retinopathy, diabetic retinopathy that happens with this disease. So if we look at this cartoon picture here, kind of showing us those common symptoms that we see with type 1 diabetes, the increased urination, increased thirst, and increased hunger, the classic triad there. Along with that, we could potentially see weight loss, fatigue, increased frequency of infections, rapid onset of symptoms. So the major symptoms of the thirst, urination, hunger, all of those are going to kind of come on suddenly. But as I mentioned, the disease has been going on for a while. So it's not that the disease just started to kick in. That damage has been happening for a while now. This is an insulin-dependent type of diabetes. This has to be managed with insulin because they are lacking that insulin in the body. There can be a family history. That can be one of the kind of the etiologies behind it, predisposition, if there's some genetic factors present in developing this. And then the peak age of onset of diagnosis, 10 to 15 years on average. So how do we treat type 1 diabetes? It has to be treated with insulin replacement. It is mandatory. It's not optional, has to be used. Oral hypoglycemic medications are not effective with this disease. They need an exogenous source of insulin because they're not producing it internally on their own. So, different ways that can be managed. Okay, at home, they're going to have to do self-monitoring of blood glucose. Initially, at diagnosis, at the onset, when they first go home, this child and the parents are going to be doing multiple finger sticks daily and potentially through the night as well, checking blood sugar levels, make sure that they're maintaining within a safe range. As they manage the disease years down the road, they may get to the point where they can have what's called a continuous glucose monitor, or CGM, and it's an amazing technology. That it's a device that hooks onto the skin, to the subcutaneous tissue, and it continuously monitors glucose levels. So that is an amazing kind of newer technology out there that type 1 diabetics can use that really helps them manage their disease a lot more effectively. Then subcutaneous insulin injections. At the start, the child and the parents are going to have to learn how to do sub-Q insulin injections multiple times a day, before meals, maybe during snack times, things like that, through the night. They might have to do a 2 a.m. check, things like that, just to make sure they're staying within safe range. As their treatment progresses, though, and if they become, proficient in managing their disease and are available or, a good candidate for an insulin pump, then that's an amazing technology that's out there now as well. In conjunction with that CGM, they can have an insulin pump, so it helps regulate their blood sugars, and automatically through the pump has a vial there of insulin that can automatically give insulin as needed, in bolusing and as a basal dose, just continuously throughout the day, kind of mimicking a little bit what the pancreas would do. So those are a couple of options there. Either way, though, at the start of diagnosis, they're going to have to be doing lots of finger checks throughout the day, finger sticks, and then they will have their insulin injections all throughout the day and night. Very close monitoring of their dietary intake. Carbohydrate intake is really big, because that's the big thing that's going to increase their glucose levels. Is when those break down into glucose, then that causes that surge of glucose intake. So closely monitoring that, very regular and routine exercise, and that can be pretty challenging with kids because they're just so active. And then lots of diabetes education. That is an absolute must for a new onset diabetic, and continued education throughout the rest of their life. It is a chronic disease. This is not something that's going to just go away. So now moving on to type 2 diabetes. This is the most prevalent form of the disease, and we are seeing rising incidence in type 2 diabetes. We're seeing more young kids and adolescent age kids being diagnosed with type 2 diabetes now, when in years past we used to primarily think of type 1 with kids, but now we're seeing more type 2 diabetes with kids. So that is a rising issue in our society. With type 2 diabetes, typically they do not develop ketosis, that state of acidosis, because type 2 diabetics are still capable of producing insulin. They just might not be as sensitive to that insulin like they used to be. So that is a big difference between type 1 and type 2. The etiology behind type 2 diabetes, there is insulin resistance and impaired insulin secretion due to various factors. There could be a hereditary component to it. We know that type 2 diabetes runs in families, and obesity is a link to the disease. The body just does not use insulin properly anymore. It could be due to desensitization of the beta cells from chronically elevated glucose. And what that does is it just makes the beta cells basically less responsive to elevated glucose levels. So with obesity, high glucose levels all the time, it's decreasing that, it's causing desensitization. And then just overall, the beta cells may start decreasing how much insulin that they're producing. They still will produce some, but just decreased. Faulty insulin receptors, that desensitization. And maybe there's another factor like medications. We know that long-term use of corticosteroids cause increased glucose levels, and those are very hard on the body and take a big toll there. So all of those are definitely risk factors for type 2 diabetes, but it is very important to know that type 2 diabetics still make some insulin. So that is a major defining factor there between type 1 and type 2. When you hear the phrase insulin-dependent diabetes, I don't want you to be confused by that and thinking that that is, basically whether, to clarify that, is just whether a client uses insulin as a medication, but rather whether the client produces their own insulin. So don't think about insulin-dependent diabetes as, oh, well, they use insulin to treat their diabetes, so they must be insulin-dependent. No, they could be a type 2 diabetic that just uses insulin to manage their disease, but whether the client produces their own insulin, like a type 1 diabetic who doesn't produce their own insulin, that's an insulin-dependent diabetes. Okay, so I just didn't want that phrase to confuse anybody, so I just wanted to kind of make that a little bit clearer there. So the risk factors for type 2 diabetes, looking at family history. Specifically, they say either a parent or a sibling with type 2 diabetes increases the risk much more for someone to then develop that. Obesity, decreased physical activity, they kind of go hand in hand, and they say specifically less than 3 times a week increases the risk there. Age, onset is usually after 40 years of age, so that increases the risk. Hypertension. We commonly see that patients with type 2 diabetes commonly have or will develop hypertension. Those two definitely correlate. Those two diseases definitely correlate with each other. So that's a big risk factor there. A female who had gestational diabetes during pregnancy, or maybe didn't have gestational diabetes but delivered a baby weighing more than 9 pounds, just a larger baby, they say increases the risk of developing then type 2 diabetes. There are certain ethnicities that are linked to type 2 diabetes: Hispanic, Latino, Alaskan Native, American Indian, Asian, African American, Pacific Island descent. Those are all more commonly associated. Women with PCOS during reproductive years have a 7-time higher risk of developing type 2 diabetes. So lots of risk factors present there. When we look at the signs and symptoms of the disease, a big differentiation here between type 1 and type 2 is the type 2 symptoms are much more of a gradual onset and can be asymptomatic for many years. So you can still see that classic triad of symptoms, the polyuria, polydipsia, polyphagia, but it's much more gradual. It's not so sudden. An elevated fasting blood sugar, and what that means is no intake for at least 8 hours, and then having a blood sugar checked. If their glucose is greater than 126 or higher, I should say, then that would be indicative of type 2 diabetes. Frequent infections, again, the sugar just increases that risk of bacterial growth. And slowed wound healing, also associated with the PBD, the vascular issues, visual changes because of diabetic retinopathy. And then insulin levels may be low where they're deficient, or normal to high, and that tells us more that they're just insulin resistant in the body. And picture here to show symptoms of type 2 diabetes, so the sedentary lifestyle, decrease in exercise, activity, obesity, all of those go together. The family history, age of onset, they say 50 years here. I've seen some resources say, though, 40 years of age. And then history of hypertension, just elevated blood pressure there, fatigue and decreased energy, just with how the disease affects the body. Obesity, as we mentioned, recurrent infections, as we've mentioned, that classic triad, the polyuria, polydipsia, you can see polyphagia as well. And then a fasting blood sugar of 126 or higher would be highly indicative of type 2 diabetes. So how do we treat this disease? The starting point for management of type 2 diabetes is how can we modify diet and incorporate exercise to help manage the disease, and sometimes that is sufficient. Sometimes that is enough. Not all patients with type 2 diabetes need to take medications to manage their blood glucose. So diet and exercise may be enough, but if that isn't, then there are lots of different oral hypoglycemic medications that we'll discuss in this lecture that can help in controlling blood sugar levels. They may also need to do self-monitoring of blood glucose at home, doing their finger sticks at home and checking those. And some type 2 diabetics will eventually need insulin because they might not be able to effectively manage with diet, exercise, and oral medications. So then they may need to also add to the regimen sub-Q insulin. So as I mentioned, it might be needed, but not required like it is with type 1 diabetes. All right, so let's continue on talking about nursing care of the diabetic patient. And of course, we always start with assessment, just like we know with the nursing process. We have to assess the patient and see where they are in the present illness. So do they have type 1 or type 2 diabetes? That's definitely important to know the difference there. What are their current glucose levels, any weight changes that they've been experiencing. Looking at their past health history, do they have any comorbidities like hypertension or CAD or any kind of renal disease? Renal dysfunction is common. Renal damage and dysfunction can be common with diabetes, so are there any issues there? And do they have a past history of gestational diabetes during reproductive years? And then some of those risk factors with family history, again, a history of diabetes in the family, parent, sibling, any heart disease or stroke, issues in the family, heart attacks, MI, things like that. And then review of systems. We need to do a good physical assessment and looking at, do they have any vision changes, skin changes, numbness or tingling in the extremities. Functional wise, are they able to manage their disease at home, physically, financially? Do they have all the resources that they need to be able to get their medications, be able to monitor glucose at home? Do they have all the funds that they need to be able to purchase all of that medical equipment? So just an overall good assessment there. And then getting, again, more health history in the physical exam. Important to look at overall vital signs, height, weight, skin, eyes, mucous membranes, lower extremities, looking for any of those changes in the vasculature, numbness, tingling, any lesions or wounds or ulcers in the feet or extremities, any edema going on. Do they have good strong pulses in the extremities? Neurologic exam, eye exam is important. Are they having any vision changes? Things like that. So a good overall assessment is very important. And then once we do that assessment, then we can formulate some nursing diagnoses that could correlate with this patient. So some examples I give you here: ineffective health maintenance, ineffective management of therapeutic regimen, because of course if we're looking at modifying diet, exercise, medications, all of that combined can be a lot to manage. And during times of like that type 1 diabetic who's in ketoacidosis, the deficient fluid volume could definitely apply to that patient. With the chronic pain or sensory perception with PVD and the neuropathy that can happen, that could apply to them. If there's any diabetic ulcers or skin issues, the impaired skin integrity. And ineffective coping, of course, because it's a chronic disease, so it's not going to be cured overnight, so there's a lot of coping that goes into it. So looking at the management of this disease and working with a diabetic patient, it's important to know that nutrition and diet teaching is key. It is so important for this disease and for managing this. There is no cure, so we have to make sure that we are managing this effectively. And the main goals in managing diabetes are threefold. We want to regulate blood sugar levels, we want to avoid complications, long-term complications as well as short-term complications, and then minimize the disruption of their overall lifestyle. Treatment modalities that are available, and it must be individualized for every patient. We have to make sure that we are creating a plan of care and disease management for the patient that is going to fit them and will be effective for each patient. So that can consist of diet, exercise, and medications, whatever combination of medications that might be. And overall, we know that early detection of diabetes and early treatment and intervention will decrease the risk of those long-term complications. So it is very important that we start treating this early on. When it comes to diagnosing and testing for diabetes, what are kind of the guidelines right now? What do we look at? How often should we be testing people for diabetes? So some things to consider. They say that patients with a BMI of equal to or greater than 25 kilos there, and having any risk factors present like a family history, things like that, they should probably be tested for diabetes pretty routinely. But if if a person doesn't have any of those risk factors present, they're not obese, things like that, if they don't have those, then maybe start testing around age 45, and then test about every 3 years. If it's negative, then test them again in 3 years. So those are kind of some general guidelines for practitioners right now on testing for diabetes. When it comes to diagnosing diabetes, we look at, of course, the blood sugar levels, but there's different ways that we can evaluate that. We consider a normal blood glucose range to be between 70 and 120, and we can look at, the fasting glucose level, but we also have available some really good technology, hemoglobin A1C. That became part of the diagnostic criteria in 2010. And what hemoglobin A1C tells us is the average glucose levels in the body over the past 90 days or 3 months. So that correlates to a percentage, and they say the guideline is a hemoglobin A1C of greater than or equal to 6.5% is highly indicative of diabetes. And then looking at the fasting glucose level, we mentioned this previously, a fasting blood sugar of 126 or greater is also highly indicative. Then a couple other ways can be tested. They can do a 2-hour plasma glucose with an oral glucose tolerance test. And with that, 2 hours after administering the glucose, if it's greater than, equal to, or greater than 200, that's indicative. And then a random plasma glucose, so they didn't fast at all, it just was a random glucose check, being 200 or greater, with some kind of other symptoms that are characteristic of hyperglycemia, that would be indicative as well. To get a diagnosis of diabetes, the test, they typically will diagnose off of 2 tests that are elevated on 2 separate occasions. So if they have 2 tests that come back elevated, the practitioner will probably have the patient come back in like 3 to 6 months, and they'll retest them again, test sugar levels again from 2 different tests, and if they're still elevated, then at that time they will receive the diagnosis. So some more information on hemoglobin A1C. It's a test that measures the amount of glycosylated, which just means blood cells that are chemically linked to glucose. So the hemoglobin that is chemically linked to glucose in the blood, and it gives a picture of the blood sugar status for the past 90 days. Can be drawn at any time. There's no special prep, no need to fast, and so that is a really nice, convenient part of hemoglobin A1Cs. And so we know that elevated A1Cs tells us that they are an increased risk for diabetes and complications of diabetes. So the values they have set out here, 4 to 5% is kind of the starting point, and those would be considered normal, non-diabetic, an A1C there. And then getting to pre-diabetes would be considered a percentage of like 5.7 up to 6.4%. And then once we get greater than 6.5%, that's typically correlating with diabetes, and that patient is in need of active measures to help lower their blood sugar level. For diabetic patients who maintain good blood glucose control, they really just need to have their A1C checked like twice a year, and that's a good way to kind of, again, manage their disease and see how they're doing long term. But for those patients who have really poor glucose control, they really should have their A1C checked quarterly. To give you an idea of what these percentages correlate to with glucose levels, so at 6%, an A1C of 6%, that's correlating to about a 126 blood sugar level. And then you can see as that increases, an A1C of 8 and 9, you're looking at around 200. Over time, as hemoglobin A1C increases, that tells us that patient is having chronically elevated glucose levels just all the time. So that is where we would find them to be in an uncontrolled, diabetic there. Looking at serum blood glucose and doing a fasting test, they have to be 8 hours without food. So a normal result on a fasting blood sugar would be less than 100. Pre-diabetes would be considered 100 to 125. And then diabetes would be 126 or greater. And then the glucose tolerance test, fasting state for 8 hours. And then they have the patient drink 75 grams of glucose dissolved in water. 2 hours after that, they will draw their glucose level. And for pre-diabetes, they say a range of 140 to 199, and then for diabetes would be a blood sugar of 200 or greater. If they are significantly elevated, above 200, the provider may even order checking the urine for ketones just to make sure those aren't present there. And then just a random blood glucose draw, just drawn without regard to food intake. And of course, we're going to see increased levels maybe after meal intake, stress, trauma, or infection in the body. Maybe they, drew the blood sugar near a site where there was some dextrose running through an IV, something like that. Steroids, of course, can affect the blood sugar levels and increasing those. So for the random glucose, pre-diabetes would be between 140 to 199, and then greater than 200 would be indicative of diabetes. So daily management of the disease, of course at home, they may need to be doing multiple finger sticks throughout the day. Make sure that the patient knows good technique on how to check blood sugars, cleaning, with alcohol before checking, and then they should use the results of their blood sugars to, adjust insulin doses throughout the day, maybe adjusting diet and exercise regimen as needed in order to maintain good glucose control. When it comes to management with nutrition therapy and diet, this has kind of been a cornerstone of diabetes management. With type 2 diabetes, we really see that it is very important to have good controlled ingestion of foods that are high in sugar and fat. And when we say that, we're not saying that the patient has to be on a no-carb diet. They just need to have very controlled intake of healthy amounts of carbs. And, the healthy carbs, things like that are okay in moderate amounts. So we also know that avoiding obesity or just maybe losing weight to get back to a healthy weight level can definitely benefit someone with diabetes. Really, a registered dietitian should be part of the patient's plan of care. They need to have them, active in managing their diet and teaching them lots of good food options that can help manage their disease. But the main goal with nutrition therapy and diet is maintaining realistic weight and making healthy food choices. The old method for diet management for diabetes is what we call the ADA diet. And what they did with this was they placed foods within one of 6 exchange lists. And all of these exchange lists were assigned a specific caloric intake. And so the patient could receive a certain kind and number of, each of those exchanges at each meal and snacks that are planned throughout the day. And they kind of broke it down between carbs, proteins, and fats and what percentage that they could have. So you can see here for each category what they could have percentage-wise. Along with that, they also recommended limiting processed foods, concentrated sweets, to help with diet management, and that, of course, it needs to be very individualized. The exchange list were foods in these certain categories, and they were assigned because they were, in similar protein, carb, fat, and caloric counts. So the main areas that they focused on in the ADA diet was milk, bread, meat, fruits, veggies, and then fats. So this example here, this chart kind of shows you how they broke those down based on a person's recommended caloric intake per day. If they were on like a 2,000 calorie diet, then you could see how much starch or bread, how much meat, veggies, fruits, milks, and then fat that they could have throughout the day. And the patient could also, exchange across categories, meaning, they could exchange one serving for another in each category, because, they say that each category, each serving correlates to about 15 grams of carbs. So this was kind of used years ago. We really don't see this used much anymore, but I think it's important for you to know this because there are still some patients who still go by the exchange list. And so it's important for you to know about it, to hear about it. So if you have a patient in the future who's using this, you have some knowledge of it. The newer method now, what we see used most commonly, is the consistent carbohydrate diet. So this is where we want consistent carb intake from meal to meal each day to another day. And it's based on kind of heart-healthy diet principles that are low in saturated fat and low in cholesterol. The majority of a person who has diabetes, the majority of their carb intake should be from those healthy carbs, whole grains, fruits, vegetables, and low-fat milk or low-fat dairy options. If you ever see diet orders that say things like no concentrated sweets, no sugar added, low sugar, these really do not reflect overall diabetes nutrition recommendations, and so they really just do not reflect all of the fat guidelines, low fat, things like that. They unnecessarily restrict sucrose, and so anyways, just know that if you ever see diets described that way, that really is not encompassing everything that needs to be part of the consistent carb diet. So some recommendations that patients are given with the consistent carb diet is to use fats that are liquid at room temperature. These are more like healthier fats, things like oils, egg yolks, high fiber foods. These are really good for the overall body, nutrition wise, as well as they can help decrease total cholesterol and LDL, and so that's going to help again decreasing that risk long term of coronary artery disease, atherosclerosis, and just heart disease in general. They also need to avoid alcohol or just keep it within very limited amounts, because what we find is alcohol can actually cause a decrease in blood glucose levels because it blocks production of glycogen, which, as we previously mentioned, that converts into glucose in the liver, and then it also can increase insulin secretion. So then those two effects there can actually cause a severe lowering of blood glucose. So the recommended guideline is for women no more than 1 drink per day and men no more than 2 drinks per day. But really, if they can avoid it all together, that's really best. And then avoiding those very high fat foods like gravies, sauces, fried foods, those definitely need to be avoided in the diet. And then carbohydrates, those are really the foods that are broken down mainly into sugar, and that's what's going to give that direct correlation of an increase in blood glucose. So the patient needs to keep the amount of carbs that they're taking in consistent with each meal day to day. And so the recommendation is 2 to 3 servings of 15 grams of carbs. The 3 basic food groups that they recommend taking intake from are fats, proteins, and carbohydrates, and they need to be using the healthy sources of carbs, avoiding the more common things where we eat carbs are like starch, fruit, high fat milks, sweets, but instead getting their carb intake from things like whole grains, whole wheat pasta, whole grain pasta, beans, fruits, and vegetables. And then choosing nutrient-rich carbohydrate foods. Again, those are very important. And rounding out the rest of the meal plan with lean meats, fish, poultry. Those are really going to help give them that overall good nutrition that they need. Then the percentage for what they can have in each of these food groups for each meal, about 45 to 60% of carbs, 15 to 20% proteins, and then less than 7% fats for each meal. And they really need to avoid high calorie foods with decreased nutritional value. That's just going to make it more difficult to manage blood sugar levels. And it's really not healthy either if the patient is on a low carb, high protein diet, because high protein without carbs is just going to stimulate insulin secretion, and without having the carb and the glucose there to move into the cells, it's going to cause protein and fats to break down, and that causes that ketoacidosis. So that's really not recommended either. And so the patient's insulin dosing, if they can follow these guidelines on the consistent carb diet, they really should see that it's going to match kind of their meal intake. And so it should be more consistent on how many units with each meal. If they're keeping that carb intake consistent, then insulin doses should also be pretty consistent as well. So some special considerations: if a patient is receiving insulin, they need to make sure that they're eating all of the food that they are accounting for in that meal for their carb intake, so that when they administer insulin, then they have enough glucose intake so they don't drop their sugars too low, that they're eating at regular intervals, that they're not skipping meals. And if a diabetic patient does get sick, there are some sick day guidelines, especially for those patients in particular with type 1 diabetes, where they really have a hard time regulating insulin levels in the body. There's definitely some important guidelines for those patients to follow. And then in general, patients typically will meet with a dietitian or registered dietitian, things like that, someone trained to help give them some really good diet teaching and managing diabetes. They need to teach them about the basics of a consistent carbohydrate diet, and it's important as you as a nurse to have an idea of what that means and what that entails, so that you can also answer questions for your patient. Don't overwhelm the patient. There's a lot of information and teaching that goes into diabetes teaching, so it can be very overwhelming. So we need to try to eliminate that and just be there as a support person and provide information in a slow, easy manner, using any handouts or diagrams, pictures, whatever's most helpful for the patient. Maybe a list that shows all the percentage guidelines for each of those food categories. Repeat any demonstrations. We never assume that they know everything. We need to make sure that we explain everything so that we don't miss giving them some vital information. Encourage questions. Use those open-ended questions that we talked about way back in PVC. Okay, encourages them to ask questions, not the closed-ended where it's a very short kind of cut-off conversation. Teaching patients about sick day nutrition. It's really difficult to manage blood sugar levels when a diabetic patient is sick. And we know with infection in the body, it will increase blood glucose levels. So the patient really needs to be sure that they're taking their insulin as usual, that they're checking their blood sugars very frequently, at least every 4 to 6 hours, if not more often. And they need to be in close communication with their physician and their endocrinologist, and making sure that they are adjusting insulin doses, according to what's safe. And then drinking lots of fluids, because there's such a high risk for dehydration, especially if they are having any vomiting or diarrhea, then they're losing more fluids that way too. If there is any nausea and vomiting going on, they need to try for at least 15 grams of carbs every hour, so that they don't start breaking down fats and proteins. If they're low on carb intake and breaking that down into sugar, they need to make sure that they're getting some kind of carb intake. I've got a slide that shows some good examples of what they can have. And checking urine for ketones, especially with those type 1 diabetics that are a high risk for ketoacidosis. And so making sure that they're not breaking down fats and proteins in the body. And then notifying their physician if their blood sugar readings are greater than 300, and patient can also test they're, at home, they have test strips to test urine for ketones. And so if they come positive for ketones in the urine, they definitely need to notify their physician right away. And if they're having a lot of difficulty keeping fluids down and maintaining fluid intake because there's such a high risk for dehydration. So for sick day food options, they have to have, carb intake in order to keep their glucose levels adequate so that they can move glucose into the cells. And so that's why it's important that they have some kind of carb intake, and all of these options provide at least 15 grams of carbs with each intake, and that's going to help prevent protein and fats breaking down in the body. So things like chicken soup, and it gives measurements here of how much, apple juice, orange juice, cranberry juice, vanilla ice cream, just any of these carb intakes. But they just need to make sure that they're closely monitoring blood sugar levels, their carb in their meal intake, and how much insulin that they're administering, and checking ketones in the urine as well may be needed. With exercise, that is definitely a big part of managing diabetes as well. We know that working muscles require less insulin to move glucose into the cells. They're much more efficient with glucose, movement into the cells, and so a well-exercised person responds much better to small amounts of insulin than someone who is not. So the benefits, it does help lower blood glucose, which obviously is good, but also can have bad effects if it causes hypoglycemia, if it lowers it too much. So following, precautions and guidelines for safe exercise. We know that exercise helps lower LDLs, triglycerides, improving cardiovascular conditioning, decreasing the risk for heart disease, and can help those diabetic patients that have hypertension, can help lower their blood pressure as well. So what are safe exercise guidelines? The goal is really exercising at least 3 times per week. A minimum of 150 minutes per week of what they consider moderate intensity. Aerobic exercise is best. Things like walking, swimming, biking, jogging, any of those are good options. They also recommend no more than 2 consecutive days without activity, and incorporating resistance training as well, weightlifting, things like that, 2 times a week helps increase insulin sensitivity. Consistent amount and time of exercise is definitely a good guideline for diabetic patients to follow, as well as avoiding exercise after a peak action of insulin. They don't want to administer their insulin, and then if it's peaking in 1 to 3 hours, don't be exercising during that time. Always having a snack available either before and after exercise, have a protein and a carb option there. And a new guideline that came out for 2017 is that by the ADAs, they recommend that prolonged sitting should be interrupted at least every 30 minutes, getting the patient up and active, at least every 30 minutes. Some considerations to think about with diabetic patients who are having a scheduled surgery. That definitely poses a challenge to usual routine with medications and what they normally take and the dosing on that, so that definitely can have an effect. Stress on the body also increases blood sugar levels, so that takes a toll on the body. Slowed wound healing is really big, and it definitely increases the risk for vascular issues, delays that healing time and that process, much higher risk for infection as well. So those are all big issues with that post-op time period when they're trying to heal. Special considerations as far as the patient being NPO, we really have to monitor blood sugars very carefully and frequently. If they were on some kind of an oral medication, they may be taken off of that for a time period before surgery and then put on a sliding scale insulin with Q4 to 6 hour blood sugar checks. So that is definitely a major change for some patients. We want to prevent a state of dehydration, so making sure that they're adequately hydrated with IV fluids, reintroduce their diet post-operatively when they get to the point that they can have PO intake, really good skin care, really good technique with any kind of wound dressing changes, and frequent assessment of the wound, and just continually assessing blood sugar levels for any hypo or hyperglycemic episodes. For type 2 diabetics who are taking oral hypoglycemic medications, there are definitely some considerations here. Some of those medications can actually be taken up to the day of surgery. One example is Actos, but some of them need to be stopped like 1 to 3 days before surgery. So then they need to be taught how to use a sliding scale insulin at home to control their blood glucose level, for the days prior to surgery. So glipizide, metformin, those are a couple of examples of medications that need to be stopped prior to surgery. So it's always important to know what your patient is taking and that we are providing them the education and communicating with them on how they might have to modify their medication regimen prior to surgery. Foot care is so important for diabetic patients, and we really have to teach them the importance of visually inspecting feet every day. They need to be looking for any cuts, scrapes, swelling, any blisters, red spots. Washing them with warm water. Really avoid soaking them for long periods of time, keeping them nice and dry. Mild lotion for the skin, keep it hydrated. Make sure nails are cut straight across. We don't want them catching on anything or tearing, and then that can cause an open sore. And if they have any major issues with like nails or the skincare on the feet, they really need to be treated by a podiatrist. They need to have that specialist on board in their plan of care. So that's very important, because we know that diabetic foot problems are directly associated with the inadequate blood supply in the extremities, the PVD that happens. They develop the neuropathy, and it's such a huge risk for long-term complications of having an amputation in the future if we cannot maintain good foot care. These are some pictures to really illustrate the complications of diabetes in the peripheral extremities and the major issues that can happen. And what happens with this, where a lesion forms, then blood and fluid starts to accumulate beneath that lesion, and then it causes additional inflammation, and then eventually that creates an infection site. And then because of their slowed wound healing and their decreased vasculature, that wound just really can take a very long time to heal, or maybe never heal, and then that is what potentiates the need for an amputation. So some good teaching points: teach diabetic patients to wear cotton socks every day, nice and breathable, and that are very soft, form-fitting. Make sure that they have really good, well-fitted shoes, avoiding any rough shoe linings. Always wearing socks with shoes as well, and they should never, ever, ever go barefoot. There's too many stories of diabetic patients who walked outside barefoot, and then a rock or something got caught, in the skin there, and they could not feel it because of the severe neuropathy, and then it causes a long-term wound infection there. And then elevating feet when possible, just decreasing any edema, wearing socks to bed, keeping the feet protected. No heating pads, just because if they do have that impaired sensation with the neuropathy, they might not know when it's getting too hot, and then that could cause a scald or burn. And, overall, the best treatment is just preventing any issues and ulcers on the feet, and then that will decrease that risk of complications. All right, so here we are going to end part 1 of the lecture, and we'll pick up next with part 2.